As you probably know, we have the three chief medical officers from the three health systems here in Omaha. I'm here today to all talk to you about the same thing, but all share a little bit separate approaches on how we plan to handle an increase in COVID hospitalizations that we've been seeing here over the last few weeks. So with that, I'm going to turn it over to the Chief Medical Officer of Nebraska Medicine, Dr. Harris Frankel. Dr. Frankel, take it away.
Thank you, Taylor. Good afternoon, members of the press. It's a privilege to sit with all of you today, hopefully to answer the questions you have, provide some clarity as to our plans to handle the surge of COVID-19 patients that we are facing, especially against the background of the upcoming flu season. Let me say this, that myself, Dr. Lydia, Dr. Ward, we represent three competitive health systems in the community, but we are anything but competitors in this fight together. Since day one, we have worked collaboratively, cooperatively, and together for the benefit of our local citizens and those in the region and across the state. Together, we're better. The patients are the real beneficiaries because of that work. Nebraska Medicine's inpatient surge strategy will incorporate a combination of routine management of core staff, investment in expanded facility capabilities, and temporary use of alternative staffing solutions to flex to capacity. Happy to talk about that in more detail as we go forward. But again, I want to emphasize that this is a collective work of your health systems doing what we think is the right thing for patients to meet their needs at the right time in the right place for the right reason. It is very important that you listen to the words of my colleagues. There are messages that we all can share with our friends and families and others in the community. And again, we appreciate your time and hope this is informative for all of you. With that, I'll turn it over to Dr. Lydia from Methodist Hospital.
Thank you, Dr. Frankel, and thank you all for joining us. Of course, we will speak first, but we will be available for questions. That's going to be a really important time and something we really stress, that we want to get the information out to the general public. Douglas and Lancaster County and Nebraska generally are seeing significant increases in COVID-19 infections. This continues to pressure us to find appropriate beds and, even more critically, staffing for those beds. Our plans consider all available options to safely care for our patients. The health systems of Omaha and Lincoln are committed to caring for all Nebraskans and Iowans that require acute medical care, whether it's COVID-related or not. Doctors, nurses, and other medical professionals are dedicated to helping our citizens. We can manage a significant surge in COVID-19 patients. However, we cannot produce unlimited hospital capacity. We need your help. The first strategy is to decrease the number of infections. It is incumbent upon our citizenry to listen to Governor Ricketts and public health professionals and avoid crowded places, close contacts, and confined spaces. Masks are a social responsibility. The best evidence available supports their utility and their safety. Wear them anytime you are less than 6 feet from others. Hand washing is also critically important. In March, all the health systems in the metro area, stopped elective surgery because of 4 reasons. 1 was inadequate supplies of PPE. 2 was concern about the potential spread of virus within our hospitals. 3 was potential staff shortages. And 4 was physical bed space or capacity. We now have adequate, although not unlimited, PPE. We now know that PPE works. We do not see our healthcare workers becoming ill while caring for our COVID positive patients. We have developed extensive surge plans for increased bed capacity, as Dr. Frankel alluded to, as I will talk about, and as Dr. Ward will also talk about. With the governor's help, we are working to obtain additional staff, and we are greatly appreciative of that help. However, we continue to need to examine all options, including elective surgery. Elective surgery does not imply unnecessary surgery. It includes cancer operations, heart surgery, and chronic health problems that worsen over time if not surgically addressed. We see patients that have more severe disease as a consequence of a fear of hospitals. This fear is exacerbated when we cancel surgery or clinics, leading to a failure of people to seek needed care. We therefore take the cancellation or postponement of these operations very seriously. However, we learned in March that if we do decide to cancel operations, we can significantly increase capacity and do so quickly, within 1 to 3 days. Each of the health systems are employing these strategies. At Methodist Health System, we currently have the highest number of COVID patients since the pandemic began. Our staff are tired but resilient. They have stepped up over the last 7 months, and they have truly been warriors in this ongoing struggle. As Dr. Frankel mentioned, we have also taken a number of measures to try and increase our flexibility and our capacity. Methodist Hospital began paring back surgical cases last Thursday, October 29th. We continue to make nuanced and nimble moves to manage our hospital capacity. On behalf of all my fellow CMOs, we are deeply thankful for the work, care, and dedication of our healthcare workers in this ongoing challenging time. I'd like to now introduce Dr. Carrie Ward, Chief Medical Officer of CHI. Dr. Ward.
Good afternoon, everybody. Thank you very much, Dr. Frankel and Dr. Lydia, for your comments. I couldn't agree more with everything they said. And I also want to echo the joy of collaborating with all of them over these last several months. It's been very rewarding for all of us to come together to try to improve care for our patients. Appreciate the opportunity to give our perspective from CHI Health standpoint on where we are currently. We have the beds, we have equipment, medicines, masks, gowns, et cetera, but our staff are approaching their limits. We have 14 hospitals across the state, and they're all very busy. And right now, along with the other hospitals in the state, we have seen a doubling of COVID positive patients in the last several weeks. No doubt if this trend continues, not just our hospitals, but every hospital in the state could be at capacity in a fairly short period of time. At this moment today, we have 197 people hospitalized in our hospitals. 47 patients are in the ICU. I will say overall these patients are doing better in all of our systems. They're healthier than they were in April because of better treatment, without a doubt. But staffing has been a real challenge for all of us. I do want to add my gratitude to Governor Ricketts and the State Chief Medical Officer, Gary Antone, for helping us funding to recruit staff. We all anticipate additional staff, particularly nursing staff, but respiratory therapy and other staff coming in the next several weeks. And I also want to give my gratitude to the doctors, nurses, respiratory therapists, and others who've stepped up. All of us have staff that are working additional shifts to help care for these patients. Regarding the elective surgery, we're taking the same approach that surgeries that are considered non-urgent, elective type procedures will be, some of these may be postponed. I want to stress, all of us have the ability to continue to do urgent or emergent procedures, but for certain types of procedures that can be postponed a few weeks to free up beds, patients will be called may be called if they fall into this category. We have a transfer center at CHI Health, just another great example of collaboration across the state that has been asked to serve as the transfer center for all COVID positive patients in all of our hospitals in the state. I want to give my gratitude for everyone as far out as Scotts Bluff who have received transfers from this. It's been a wonderful collaboration. But I just want to also stress there are times now that we've been taxed enough that we're having to go on rotations, and the hospital closest to the patient or the hospital that the patient may want to go to may not have the capacity. And we've all agreed to a rotation type process where patients may have to go to the hospital that's across town or even in other cities at times. Our critical access hospitals have also stepped up and are keeping many of these patients also that are appropriate for their care. And so just lastly, again, my gratitude to Methodist Nebraska Medicine for their collaboration through all of this. We're seeing the best in so many people. I can't stress enough, again, like Dr. Lydia said, the importance of social distancing, wearing masks. There's no room for further debate about the efficacy of masks. Please continue all you can do to keep yourself and those that you love healthy.
Now we can just open it up to anyone who has any questions about anything that the folks talked about. You heard Dr. Ward allude to what we've seen over the last couple of weeks. I do have a graphic that will depict what that kind of looks like. So I want to show that to you before we get any further along. So there's the graphic we'd like to show you that shows where we were 10/17 and where we were 10/31, the 91% 14-day growth. And it also talks about where the estimate could be by the middle of November if we don't kind of make some attempts to stem the tide. With that, I will open it up to questions. If you do have a question, just feel free to start talking, and we'll try not to talk over each other too much, but make sure you're muted if you're not talking.
Dr. Lydia, this is reporter Rudolph Sinida with KMTV. Can you please just go in a little bit more depth about the elective surgeries, maybe a timeline for when you guys are stopping those and when those can possibly return, or is that just up in the air until you guys see how COVID is moving forward?
Yeah, thank you for the question. So Methodist actually stopped some of our surgeries back Thursday of last week. So we've already begun that process. But I want to stress, and I appreciate your question, because the key to this is that we want to be nimble. We want to make sure that we continue to care for the people that do need care, but that we stop surgeries just in time so that we can maintain capacity. So we know that if you have an operation, you're typically in the hospital somewhere between 1 and 3 or 4 days. And so by stopping that, we can predict on basically a pattern of how quickly we will have beds that become available. And that is an ongoing process. In fact, we do that all the time now. We do that with our ED admissions. The nurses, I've had an opportunity to get a glimpse at what the nurses, the nurse managers and the administrative leadership does in order to create capacity each and every day. We have, as you might imagine, not unlike a hotel, we have people that come in, that stay a period of time, and then that go home, and we keep those beds churning all the time so that it's predicated on both admissions and discharges. And so we want to keep a very fine line on that. We want to have some capacity, as the governor has indicated in the mandate, the directed health measure. And so we do that, but we also look ahead 1, 2, 3 days into the future to predict which cases and how many cases we need to stop, based not just on numbers, but on the types of beds that would then come available for our COVID patients or for our other medically sick patients. And I think that's another thing I really want to stress is that, just like Dr. Ward mentioned and Dr. Frankel, probably 15% or so of our capacity is COVID. The rest of it are sick people with other healthcare issues, cardiac, diabetes, and many other things. So we need to continue to care for those as well.
Thank you, Dr. Lydia. Dr. Frankel, could you just go a little bit more in depth about Nebraska Medicine and how you're dealing with elective surgeries?
Yeah, certainly. Thanks again for the question. We too have begun to dial back our daily surgical admits. We actually started today and looking at those cases initially that may just require a single night stay post-operatively. And we are able to repurpose other care areas, PACUs, other procedural spaces adjacent to inpatient units where these patients can be safely recovered and cared for in that immediate post-operative period that frees up inpatient beds for other individuals needing those. We will, similarly, as Dr. Lydia has pointed out, and Dr. Ward as well, you know, we monitor this not on a day-to-day basis, but literally an hour-by-hour basis, because things can fluctuate. You know, the other thing that we have to be mindful of is that we're in a different position today than we were back in the spring. Many of the things that we are doing today are for individuals who, by virtue of our delaying non-urgent procedures in the spring, have now come time where they need to have those done. And so, as Dr. Lydia rightfully pointed out in his initial comments, what is considered elective is not necessarily medically unnecessary. There are many medically necessary procedures, as Dr. Lydia alluded to, that we could safely delay without changing their outcome for a given period of time. And for many of those individuals, their time has come when those procedures need to be done. The other thing that we balance in Nebraska Medicine is that we have a robust trauma service, as you're all aware. Nebraska Medicine and CU-MC Bergen Mercy are level 1 trauma centers. And so we have to continue to care for those patients. We have a number of other individuals for whom we provide complex care to, cancer patients. But we are paring back those surgeries that we can safely do and recover in alternative spaces to create inpatient capacity. The other thing, as I alluded to, is that we've modified existing nursing units, pre and post anesthesia areas, outpatient procedural areas, et cetera, to create additional capacity as the surge necessitates.
Dr. Lydia, I have a question for you. When you see the new rolling averages in Douglas County, 49 per 100,000 and a 21% positivity rate, where does that hit you on the freak out scale?
Well, you know, I think, thank you for the question, Brian. It's actually, you're absolutely right. What that portends is, you know, basically the infection number that we see on a daily basis or a rolling 7-day average gives you a reflection of what the hospitals are likely to see in a week. And it gives us then the idea of what our ICUs and our ventilatory capacity might be in 2 or 3 weeks. So that's the natural progression of this disease. And so as we see those numbers increase, you're absolutely right. We anticipate that we will be seeing more and more. And that's why I really want to stress a number of things. Again, one is these non-pharmaceutical interventions. It's so important that we start to get a handle on something 2 and 4 and 6 weeks down the road. We've got to stop the transmission. You rightly pointed out this 21% positivity rate. That's, you know, clearly that's as high as we've really seen since early in this pandemic. And from a sustained standpoint, even more. And the absolute numbers likewise are also higher. As Dr. Frankel said, though, we can be nimble. We can actually reduce capacity in some ways, and we can also increase capacity by doing things like opening up our PACUs, opening up, that's the post-anesthesia recovery unit, the gastrointestinal labs, other places that we typically do other care for in that space. And then we can move some of that, or we delay some of that. And so our anticipation is that we will see more COVID numbers. We will see higher hospitalizations. The graphic, I think that Taylor showed, you know, projecting up to 540 or so, certainly could be the case in 2 weeks. We would be, I think, incredibly pleasantly surprised if it didn't increase at least some. Whether it hits that 540 is hard to predict, but I don't think there's any question we're going to see more numbers probably during this week and next. But I want to also say, since you asked the question about the freakout scale, it's really actually very important. And one of the, I'd say one of the major reasons that we initially got together as health systems and CMOs is that, we're competitors. We're all competitors, but we absolutely want to do what is right for our community, what is right for our staff, and what is right for the state of Nebraska. So we absolutely are working together and trying to do this as much in lockstep as we can. We're understanding that each of us have slightly different needs. But these are all part of our strategy to actually decrease the, maybe hysteria is too strong a word, but the panic. Because what we really need is people to understand that we can create capacity, we can care for people, but every citizen has to do their part. You have to wear a mask. This is not a political statement. This is about trying to decrease the spread of this virus. You have to socially distance. You have to wash your hands. You have to avoid these crowded places and the 3 C's as the governor and Dr. Antone have rightly pointed out.
Can I ask a question here? This is Ben Salazar. Let me preface my questions actually by saying that I am a community advocate and a community contractor with Douglas County Health to share these messages on billboards, bus benches, print, media, the like. So that's what I've been doing since July. But it's been my observation that there are some issues that have to be resolved. And you as medical professionals, medical experts, I think are in the best position statewide and locally to give this advice. And one of the messages that we've been getting, actually messages that we get as a community, are inconsistencies between what some politicians are saying and have said and what medical experts say. I tend to follow what the medical experts say on these issues. That's number one, the inconsistencies. Number two, I know that there are a lot of lessons that will be learned from this pandemic and how it strikes the community and where the services have been lacking, especially medical services such as North and South Omaha. Is there any thought given among the competitors, as you describe yourselves, after this is all over, to form an emergency crew, an emergency collaborative among the medical experts in preparation, heaven forbid, for the next health crisis or the next pandemic? The other thing that I've seen in South Omaha is the protocols involved with registering for the testing part. Some of these protocols in some units have been prohibitive. A lot of folks have tried to register to get tested, but because you have to go online, even including for people who don't have computers or smartphones, it makes it very difficult for many people, especially in low-income communities such as South and North Omaha, to even get registered. And I'm wondering whether or not that can be somehow remedied as we move forward. The other thing that I've been wrestling with the last couple of months are mobile units. We have established testing sites that have been set forth by either the state or in some cases by some of your hospitals. But there are no mobile units that I thought would be provide some efficiency, some efficacy for the communities, especially North and South Omaha, and why we don't have a push towards acquiring mobile units and making the protocol for testing much easier than it has been in the last several months. This has been very prohibitive from my own observations. So I don't want to inundate you with more questions, but those are some of the concerns that I've seen just in my own participation with this virus in the last several months.
Ben, we appreciate the perspective you bring, and you do obviously raise some excellent points there. And I think we are definitely learning as we go in some regard, trying to get better as the pandemic carries on. So I don't know if any of the CMOs on would like to address any of the individual things that he brought up. but feel free to do so if you would like to do that at this time.
Yeah, I'll make a quick comment here. And again, thank you for your comments. I think they're spot on. Let me address the issue of us continuing to work together. I think it's fair to say that the real benefit that the three of us with our other CMO colleagues across the community and in Lincoln and quite frankly with those across the state is that this has been an incredible experience for all of us. And it has proven to all of us that clearly working together to solve problems for the citizens of the state of Nebraska and our region is really what it's about, doing the right thing. And we have found this experience incredibly valuable. But you know, we've been working together, many of us, for quite some time. And I'll use the example of trauma with Nebraska Medicine and CHI.
Now, a 6 News Decision 2020 election update. Now.
So
Sorry about that. We've taken care of them.
Well, I think maybe that's a good time to say that never in my life have I found a political solution to a philosophical problem worthy. In any event, we've been working with CHI for many years in our metro trauma services, caring for patients, and that's just one example of where we've worked together. We fully anticipate going forward that perhaps this collective work relative to the pandemic has got us to a different tipping point where the benefits of ongoing work together to address problems that you have rightly elucidated makes complete sense. And again, I would say the citizens are the winners. It makes us all better. It creates a better environment for the members of our community and region. And we see that as an important mission in the work.
Yeah, the only thing I want to add to that, Ben, I appreciate your question and all you're doing for the community. One of the things that I've learned a lot about through all this is the great work that our health departments are doing. And just one example of collaboration, our health departments, our community coalitions, HHS, the governor, Gary, there are so many resources all coming together to bring us all together, in addition to some of the examples that Harris gave. And yes, there will be a great deal of good coming out of this with greater opportunities to collaborate. But it's amazing, all the people. Every morning at 9 o'clock, essentially, we've had calls where everybody, it's hundreds of people, are all looking at all this together, how we can help care for the people in our state.
What about the question of protocols and registration, which has been prohibitive in many cases for people, especially from low-income communities? How can that be remedied and made more available to people who just want to get tested?
I think there are a number of efforts that have been started, Test Nebraska being one. Nebraska Medicine has launched some protocols and done some things in that regard to help with community testing. The issue of rolling testing site sounds great in theory, but not being a scientist myself, I'm not sure if there are any hiccups with regard to that. But rest assured, you have planted some great seeds in the minds of some really important people here. And I think these are some questions that we can take away here and start to think about and try to improve upon as we go forward. We do have some questions from people who are on the line. Josh Funk with the Nebraska Associated Press would like to ask, how concerned are you about having the staff needed to handle the current surge in COVID hospitalizations? Have you all started to reduce elective surgeries? We've touched on the reducing of the elective surgeries. Haven't touched as much on the staff issue. Someone would like to address that, how we're doing staff-wise, because space in many cases isn't an issue. You can't, in some cases, create more staff, even though there are some efforts out there to do that.
Yeah, I think that's a great question, Taylor. Staff really is our biggest concern. The frontline workers, the heroes of this pandemic, if you will, are an incredible group of people. And you heard Dr. Ward and Dr. Lydia allude to those individuals earlier. And I would absolutely echo their comments. This is a group of individuals, physicians, nurses, all the way down to the environmental service workers. These people who've been they have been incredibly resilient, and morale, for the most part, has been high. But I think we would be foolish to say that, people are tired, as Dr. Lydia pointed out. People are becoming weary. That being said, I think that we remain confident that because of the type of people that have elected to do this work, they will remain strong. They need support. And they need support in two forms. One, as was alluded to, we've been afforded by the governor some dollars to look for travelers to help support the existing workforces and maybe allow for some redesign in the structure of our workforces. That's not easy work. We're competing with 50 states for these travelers. And everybody across the country are in similar predicaments as relates to their staff. Number two is that staffing is imperative to open more beds. And without the staff, we can't create the capacity that we otherwise could, say not having the staff. I think that it's going to be tough. I am confident, however, that people will continue to step up. But we have to be mindful about the fact that this has been a long haul and that we need to continue to support them in every way that we can. And I'm confident that they will continue to do great work. But it is a concern.
And I'd like to add to that there are ways that the governor and Dr. Antone and Chief of Staff Matt Miltenberger have done things to help us with getting travelers, but also with helping some of our own staff to take additional shifts. It's very fatiguing work, but having that support has been also incredibly valuable. But the third thing, and Ben, maybe to get back to something that you brought up so many good points there, but one of them is, how do we get our communities to understand that all health is community health, that we need to have a broad reach into all communities. And one way to do that, and the plea that I would, I guess, make, is that people that are even remotely interested in health, consider being a CNA, a nursing assistant. I believe the state is willing to try and help with scholarships to get that taken care of. And it would be incredibly helpful if the youth and people that have other positions or that are looking for work would consider doing this work. It is very important to us. It's something that allows the RNs and the nurse practitioners and the physicians to extend beyond their practices. And we really want to stress that, this is all about community. And Ben, with your reach, if you could help to get more people interested from your communities, from South Omaha, from North Omaha, from West Omaha, it doesn't matter. We need to get more people involved in this, trained, and bring people into the healthcare system, because that's actually the way we can best help, because you have a lot of great ideas. And it's just sometimes a matter of the right people being talking and the right people listening. So I would end with that.
Can I offer this, Doctor? I think you make a great point there about recruitment in our communities, especially for bilingual staff. Mm-hmm. And I don't know all of the specialties that you're defining, but I know healthcare workers in kind of a broad generalization is what we're talking about. But I'm working through funding from the CARES money. And but I think if you all have an idea to do a collaborative recruitment effort, because I think this is very important. I thought about this. How can I do this? Well, I'll be glad to join with each of you or collectively with you to do more recruitment and to aim into the South Omaha community where I work, and especially the recruitment of bilingual staff, people who can be trained. Now, I mean, you can't do it in the short run, I know that, but we can start. We can start to recruit folks to come into this kind of a medical field. Several years ago, I was invited to UNO to a class, a summer class or Hispanic students. And as it turned out, a friend of mine was teaching this class, and there were about 25 students. I think 99% of them were young women. They were in I think it was a kind of like a pre-nursing class. And I was greatly astonished at the sheer number of these young Hispanic students, female students, who were considering the health field, the nursing field. So the students are out there. We just need to develop a recruitment tool or tools to bring them to the forefront and guide them to your respective institutions. I'd be glad to do that.
Well, that would be incredibly helpful because, as everyone knows, nursing is always a major recruiting endeavor from all of our organizations, and whatever you could do to help Ben to further our efforts in that regard would be greatly appreciated. So we do appreciate you bringing that to the forefront. We do have some other questions I want to get to, and then we'll get to some folks who are on the line, but people have typed in these questions. The CDC had mentioned before seeing COVID-19 cases in people that were admitted that they've been wearing a mask during a potential exposure or outbreak. Does that attribute to some members of the public just not knowing every factor that goes into wearing a mask in public? Example being social distancing, ventilation, the patchwork of efforts that needed to prevent the virus from spreading.
Yeah, I'll take that. So let's think about what a mask can do. A mask can block the spread of virus out, the particles as you speak, and a mask can also, to a lesser degree, protect you from breathing those in. So there's really not a lot of question about whether it decreases the risk of spread and the severity in those that do get it if people are masked. The other thing I would say is that study that you're quoting, where 85% of people that got COVID were wearing a mask, the reality is most of those states had mandates and most people were wearing masks, but not all of them. And the places where you don't wear a mask, obviously, is when you're eating. And so you're in a restaurant or you're in a group of people eating, you don't have your masks on. And that was actually the strongest correlation, was being in a confined area, even though you normally were wearing masks. And so that's just another piece to this whole puzzle.
Another question we have is about not seeing much behavioral change, seeing crowded restaurants, busy streets, plenty of traffic. Some may say that the public has kind of gotten tired of hearing the message. What thoughts do you have on breaking through this message that has been kind of somewhat on repeat for a while now? But how do we break through and beyond what we're doing today, try to get this message to the folks who need to hear it most?
Well, I was going to say just what Dr. Lydia said. If all of you can help spread that sort of message, that is how we do it, because we've got to have personal responsibility. It doesn't look like we're going to get any more mandates anytime soon. So we need to be responsible. We need to be very careful around weddings, even though there's not a restriction on the gathering for weddings. Don't go to a wedding reception with hundreds of people and get within 6 feet of people and start talking to each other. Wear masks if you're going to be within 6 feet. Those just this personal responsibility, stressing the importance of that. You know, and again, it's so frustrating that there are some that still believe that masks aren't effective. One of the examples was, you know, we have a mask mandate in Lincoln and in Omaha, yet the cases are still going up. So that must mean masks aren't working. That's not the case at all. It's the fact that people are still not being responsible in other settings. They're not wearing their masks 24/7. When they're going out to social settings, eating, they're sometimes breaking those rules, and that's what's still leading to cases. So whenever you can, stay 6 feet away, wear masks, trust the medical professionals.
Well said, Dr. Ward. We do have another question. Is there a more exact timeline for delaying elective surgeries? How long could it last? We've given a little bit of idea that Methodist did it last Thursday, I believe. Nebraska Medicine started today. How long could it last? That's the question.
That's a great question. I don't know that any of us have a crystal ball. I think we'd like to say it's not going to last long, but I think that we know the reality of where we are currently. And let me again emphasize the points made by my colleagues, Dr. Lydia and Dr. Ward. We all have a role to play in reducing the rate of transmission of COVID-19. And if we can do that effectively, and if we can adhere to the non-pharmaceutical interventions that we've discussed, and all of us carry that message to our family, our friends, and others, we have a chance to shorten the duration at which we have to do these things in the healthcare facilities. But if we fail to do that, our ability to provide the capacity to care for people who need hospitalization will be exceeded. As Dr. Lydia rightly pointed out in his initial comments, it is vitally important that people accept the personal and social responsibility to follow these non-pharmaceutical interventions that we've described. That ultimately is going to be the key to being able to say, listen, we see light at the end of the tunnel as to a finite end to limiting some of these services that we otherwise would provide.
Another question, about 40% of the COVID-19 patients in Lincoln hospitals are from outside Lancaster County. Are your hospitals seeing a significant number of patients from other areas, such as transfers from critical access hospitals?
Well, I can take a stab at that since we see those numbers every day as part of the State Transfer Center. Absolutely, there is a lot of disease everywhere. We all may remember back St. Francis in Grand Island was one of the first hit with all of the packing plants. They are back to numbers greater than they were even back in April and May. I do want to say, you notice the packing plants, we're not seeing outbreaks there. And one of our presidents recently toured one of them. It's astounding the work that they've done. You walk down catwalks or hallways, it's impossible to pass anybody on these catwalks. The separation, the masking they've done. No doubt they may have some immunity, but I think that's another great example about masking, social distancing, what a difference it makes. But clearly, and I want to say we're all knowing, all you have to do is go to some restaurants out in the western part of the state or some businesses. People are not wearing masks, and that's where we're seeing a lot of disease. And we're not seeing these pockets anymore. We're seeing it evenly dispersed throughout the communities. So our hospitals in Kearney, Grand Island, even out Scottsbluff, they're all completely full, including the ICU at times from these patients.
Our next question, should anyone currently scheduled for a non-urgent surgery expect a call about it being postponed, or is there still a chance some individual surgeries won't be postponed?
I think the best thing is to talk to your physician and get a better sense of where you lie on the class, what we call there are 5 different classes from A being emergent, life-threatening, must be done right now, urgent being 24 hours. The class C those are things such as cancer operations, operations on your heart valves, those kinds of things that are important, that are timely, but don't absolutely have to be done today or tomorrow without an adverse outcome. If you're one of those 3 groups, then it's probably not real likely right now that you would be canceled. On the other hand, this is the thing, I know I've said it several times, but I want to stress how the criticality of nimbleness here. We are really looking at this on a daily basis, making game time decisions. And so while what I have recommended to our surgeons is that when you schedule a case, you talk to the patient about the possibility that they could have to be, it's possible they may get a call the day before and have to be canceled. And believe me, we understand how disruptive that is. People have come in from out of town to help, all of these things. And the other thing is, that it's frightening for the individual to have that sudden change. So we don't want to create unnecessary fear. On the other hand, the hospitals are safe. So I want to really stress that. It's not, if you're having an operation, you don't necessarily need to have a significant fear that you're going to get COVID. That doesn't mean it's not possible, But we do all kinds of precautions to prevent that. Once again, PPE does work. It is very effective. It's not 100% foolproof, but it's very effective.
Quick follow-up to that question. Can you clarify all elective surgeries or just elective surgeries that require an overnight bed? And not all elective surgeries, but what about surgeries that don't require an overnight bed? In most cases, would those still be going forward, or can we say that at this point?
Yes,
We're all taking that position. Bill, go ahead. Go ahead, Bill.
Sorry, Carrie. Yeah, we are, as Carrie said, we're all taking that position that right now we're doing those that don't require a bed. However, again, the thing that could possibly change, we all have, as part of our strategy, using our post-op recovery units as potentially additional bed capacity. If we do that to a significant degree, then you don't have those beds available for post-op patients. We would then start having to scale back those as well.
We know staffing's more of a problem than actual space, but how are the hospital systems preparing to make more room other than reducing elective surgeries? Are additional COVID units being made inside hospitals, outside tents? Are they being considered?
From CHI Health standpoint. Harris, go ahead.
Go ahead.
I was just going to say real quick, from CHI Health standpoint, we do have beds. We don't see anywhere near the need for a field hospital or significant changes. We are focusing some of our staff that we will be getting on certain units, which we think can more efficiently deliver care ideally. So in some settings, we are trying to create units. Otherwise, we have, the census is high enough, we have COVID patients in various units throughout all of our hospitals. Harris, go ahead.
I would echo what Dr. Ward said. We have been able to modify a number of nursing units. We've opened up semi-private rooms on COVID designated units to increase capacity. We've used alternative locations, as I alluded to previously, to care for patients. But at the end of the day, no matter how many beds we have, we need to be able to staff those beds. And that's really where, a great portion of our focus is right now, is being able to meet the staffing needs of the bed capacity that we can create through some, operational innovation. That would conclude my comment.
And I would just add one more thing, and that is we're working together with all the hospitals, including the specialty hospitals in the areas in Omaha and Lincoln, to see about what their bed capacity, and maybe, in fact, definitely more importantly, what their nursing capacity could do to help if in the eventuality that we need to go into those kinds of alternate arrangements. I guess I can speak for the three of us when I say, and many others actually, that we are looking at multiple different strategies depending on how this goes. So sometimes an ICU capacity issue may be a problem. Other times it's a bed capacity. Other times it's that we can't get patients back to their care facilities because they've tested positive. And so we have really quite different needs, and that fluctuates, as Harris mentioned, on an hourly basis. So we're constantly looking at what is our acute future need, and how best can we then achieve that. So for example, if ICUs are the criticality, then stopping a bunch of operations doesn't really change that, because the vast majority of those don't go to the intensive care unit. So, and some operations that do are absolutely life-threatening and have to be done. So again, it's a very complicated web, but I do feel like we have a number of strategies that we've talked about here today that give us, some confidence that we have the capacity to care for our community. But again, it comes back to, we can't do this indefinitely, and we must have everyone taking that social responsibility to do their part. This is truly a community-wide need. And I'd maybe finally end with, you know, the thing about COVID is many people have known somebody now with COVID. So it's not a mysterious illness that we didn't have anybody in our community perhaps that saw it, because many of the initial people that had it were those that were in South Omaha or were in Grand Island or Sioux City, places that we didn't have a direct line of sight necessarily. Ben, of course, you do, but I'm saying that what we really need to understand now is this is absolutely ubiquitous, and it was then too. We have to understand this is a disease of our community, everybody in our community, and even though many people do very, very well, and that's wonderful, and I'm glad they do. The more people that get this, it's just probability. The more of them are going to get sick. The sicker they get, the more they're going to need a hospitalization, the more they're going to need an ICU, the more they're going to need a ventilator. So it really is a matter of looking at probability.
Very well put, Dr. Lydia. I have one more question written, and we're about 3 minutes up from finishing this off, so I'll squeeze this one in. It's November now. Are there concerns on the public health side with holidays like Thanksgiving and Christmas? Dr. Cliff Robertson with CHI has mentioned quarantining after attending a family gathering with extended family members. I hadn't heard that, but concerns about Thanksgiving and Christmas with those on the horizon, you know, the favorite times of year for many families, and everyone gets together and drives to different parts of the country. What are your recommendations as far as that goes?
We may all have a little different perspective on this, but since CHI Health was mentioned, I'll go first. You know, and I've heard this discussed a lot on national news. This is not so different than the multitude of other holidays that we've had to deal with since March. You know, my wife and I both have parents in their 80s, and we've made some tough decisions about limiting family gatherings. We're not sure what we're going to do over the holidays, but it's just wise to the same thing, social distancing, wearing masks when necessary, and that's a personal decision people have to make about what they're going to do with their family over the holidays. Certainly, if we were around somebody that turned out to be positive when we had a significant exposure, I would recommend a quarantining afterwards.
I would completely agree with Dr. Ward. I think it comes down to a personal decision, value judgment. I would not necessarily disagree with the comments that allegedly Dr. Robertson made. I think that's good practice. I can share a story relating to a good friend of mine who attended his brother's 60th birthday. It was a large gathering with people that came from all over, and that proved to be a vector event, if you will, where a number of individuals became ill as a result of COVID-19. So again, it's I think discretion is the better part of valor, and we all have, as you heard us say, we all have the opportunity and the responsibility to make this better and to get us through this. And I think people have to be mindful of that. And if you choose to get together, wear a mask, keep your distance, and if necessary, put yourself in isolation afterwards and monitor just to be safe.
Okay, we'll make this the last question. What are your thoughts on the current DHMs? As you've said, we're asking people to follow the same personal responsibility since the beginning of the pandemic. Do we need new, more strict DHMs to limit the spread? What would you like to see?
Yeah, I guess.
that is a little touchy one there.
Well, you know, I think that I would leave the political decisions to the politicians and to the health advisors in that spectrum, because I think they understand what works best in terms of what our populace will adhere to. So what I would say is that whatever is necessary to get people to start taking this seriously, and if that means we have to decrease the number of people in restaurants or even close them down, then I think whatever is going to be necessary to stop this is probably the right answer. But I can tell you with 100% certainty, I have got enough on my plate. I'm glad I don't have to make that decision.
I would agree.
Well said. The only thing I'd add to that is to say these are tough decisions that our leaders have had to make, and they have been wonderful about collaborating with us. They've not made these decisions in a vacuum. They've been actively present at all of the meetings with the health departments, community coalitions, physicians, and have been on multiple private and large group meetings with all of us trying to make these decisions. So that's all I would add. So.
And Carrie, I couldn't agree more. I'm glad you said that because, I think we need to also credit them for what they've been doing. We've had calls Saturdays, Sundays. Dr. Antone's phone, I start on him at 5:45 in the morning, and I know we have calls in the evening. So it's really, we certainly believe strongly, and I know I can say this for all of us, that the state has been working with us in partnership. They've helped, they've listened to what our advice was, and certainly we greatly respect them and appreciate what they've done.
Yeah, it's certainly a balancing act, no doubt about that. So with that, we're going to wrap things up. Dr. Frankel, Dr. Lydia, Dr. Ward, thank you so much for taking this time out of your schedules to share this important message. It really is all about the trends that we're seeing and how long it takes those trends, what's happening in the community now, to turn into hospitalized patients. And so we really want to share that message as pointedly as we can, and to spread the word that all three of these health systems, although we are competitors, we are in this for the betterment of all Nebraskans and people across the region, and we really just want the best for the health of you, your loved ones, your friends and neighbors. So thanks so much for sharing your wisdom with us today. If anyone has any further questions, feel free to contact me. Otherwise, maybe we'll do this again sometime once things start to look a little bit better. So thanks everyone, thanks to the media, and everyone have a good afternoon.
Thanks, Kevin.
Thank you all.
Thank you.